We are discussing Rhesus Isoimmunization today. Rhesus Isoimmunization is a very important condition as it teaches us the basics of blood groups, how they are classified, how we, the mother and the baby, react and adapt to various changes among them, and it is a story of very successful usage of our understanding about blood groups and how their reactions are, and developing ways of treating them. And as a result, this disease is not as common as it used to be. It's a success story of modern obstetrics. So our objectives are to define what is hemolytic disease, why it is important, the pathophysiology, preventive actions which has reduced the disease, and then list out some of the clinical presentations of fetal hemolytic disease and the principles of maternal assessment and fetal assessment in a fetal hemolytic disease. And then we list out the techniques of assessment, including the non-invasive techniques which we are using now, and prognosis, explanation to the mother in simple language. So what is fetal disease? Our blood groups are actually molecules which are situated or projecting from the cell membrane of the red cells. So it's a lipid bilayer. There are some molecules which are only anchored to the outer part of the lipid bilayer. There are some antigens which are passing multiple times between the two sides of the lipid bilayer. All these antigens are proteins. So some of them are single proteins, some of them are multiple proteins. Sometimes you have only glycosaminoglycan type of antigens like ABO group, whereas RH and KID are proteins plus aminoglycan antigens. So all these are protein glycosaminoglycan molecules which will act as antigenic molecules to the immune system, and they will respond. In general, the fetal and maternal circulations are separate, but occasionally fetus can send blood to the mother, and mother can send her blood or serum components to the baby. And if a fetal cell enters the maternal circulation, it will trigger an immune response mediated by IgM and IgG production in the mother. And that IgG can occasionally cross through the placenta and cause fetal hemolysis, because IgG is a smaller molecule, whereas IgM is a larger molecule, generally impervious to the placenta. So the placenta doesn't allow IgM to cross, but IgG can pass through and wreak havoc at the fetal site. Red cell antigens are several, about 300 have been described, and apart from Rhesus D antigen and its variants or alleles, there are some other antigens which can cause hemolysis or raise original antigens. One is KID, another one is Duffy, and KEL, and MNS, all these are antigens which are capable of causing hemolysis in the fetus, but they are rare. The commonest, or 85% of all these hemolytic diseases caused by red cell antigen, is caused by Rhesus D antigen and its alleles. This is now, as I mentioned in the introduction, well under control because of the discoveries made over the last 40-50 years. The ABO system was the first system identified, and the next one was identified a couple of years later by the same person, which is the Rhesus system. Rhesus system is a set of antigens which has about 40 types of antigens. So they are numbered in English alphabetical letters. But the most important ones with regard to potential for antibody genesis, or the ability to raise antibodies, are these 5: capital C, capital D, capital E, simple C and simple D. There is no isoform or subtype of D antigen which is simple D. The parent generally contributes one or other antigen to the offspring. Say the mother can transfer capital C and father can transfer simple C. And each of these antigen pairs, say 1 or 2 of these, can be there in the baby. So an individual can have capital C, simple C, capital D, simple C, capital D, simple E, capital E, simple C, like that. So they can have either same isoform, which is homozygous, or mixture, which is heterozygous, depending on the type of antigen they have. Generally, when we group blood grouping, we don't then look at it in that detail, but if it is necessary, we can subtype them in the blood banks to determine whether they are homozygous or heterozygous. Those who carry D antigens are designated Rhesus D positive, and it is a trait which is autosomal dominantly inherited. So you can see now all these red cell antigens are actually genetically coded, and in future we might probably do away with this serum based typing of blood, because if we can go for the genes directly, it will be much more simpler and can be manipulated easily. So that is an area where there's active development is occurring, and probably in near future it will be a practice to type people based on genetically identified blood groups rather than taking blood and doing it with serum. And now we'll come back to our D antigen. If somebody has even a single D antigen, whether they are heterozygous or homozygous, we call them D positive. So rather than saying Rhesus positive, it is better to call D, capital D positive, because someone else can have C, they still simple C antigen, they are still Rhesus antigen positive. So it will make room for confusion. So it is better to say the type of antigen which is there. If you have capital E, you can say RH, capital E antigen positive. Immunogenicity, or the ability to raise antibodies, varies between these rhesus antigens. Capital D, obviously, since it is the most common antigen type, has the highest ability. Next comes the simple C, and the next in line is capital D. So this is the antigenicity potential of all these rhesus antigens. So if a rhesus negative mother carries a rhesus positive baby, if the fetal cells get transfused into the mother will raise appropriate antibody to that antigen, because it is not native. Mother is Rh negative, so she doesn't have any rhesus antigens in her red cell. So to her body, any positive cell is an alien. So she will develop antibody, IgM and IgG. IgMs will remain in the mother because it cannot transfer through the placenta, but IgG can cross. Since mother's blood volume is about 100 times or more larger than the baby, she will have a large pool of antibodies. They will all go through this tiny circulation in the baby and destroy all cells which has a positive antigen coming out of its red cell membrane, and that will cause hemolysis of the fetal blood. So the poor baby's fetal cells will all lyse that it will have anemia, and anemia followed by cardiac failure, and then edema and death. So that is how the fetal hemolysis kills the baby. As I mentioned earlier, other antibody systems are there. Some of them like Duffy, Kell, CE antibodies also cause fetal disease. And actually, some antibodies like anti-Kell antibodies can even not only lyse the red cell, it can even damage the bone marrow. So it can cause bone marrow aplasia and give rise to aplastic anemia of the fetus. So it's actually more dangerous, but luckily less common. But if you see somebody with anti-Kell antibodies, keep in mind the baby's bone marrow may be suppressed. So even if the small amount of antibodies are there, the damage is higher because it will go and damage the production site of red cells, rather than the ones red cells which are circulating in the circulation. So these are the common red cell antigens and antibodies which can cause hemolysis. Uncommonly anti-E, anti-C, CE, KB, or the antibodies against LEA or LEB or P system are not documented. All other antibodies will have some sort of a antigen antibody reaction between the mother and the baby. So broadly speaking, when we screen somebody, we should really be screening everyone for all these combinations of antigen antibody. But since it is not very economical, we generally screen only for anti-rhesus antibodies. Others are done if the rhesus system is not there, but if there is evidence of hemolysis only. So when we screen, ideally we should be asking, rather than rhesus antibody screening, it should be unexpected antibody screening, because in normal life, any person's blood group will have A or B or other blood antibodies. They are all expected antibodies. So if something which is not expected are there, they are called unexpected antibodies. So any antibody against any of these types of blood groups are unexpected antibodies. So in other countries, they do screen the whole against the whole system of antibodies, antigens, red cell antigens, and they treat it as unexpected antibodies. In our country, because of economics, we usually screen only for anti-D antibodies, but in the private sector it is available. So the incidence of antibodies against Rh blood groups depends on the type of population. Sri Lankans, we have about 4.6 to 5% Rh negative proportion. In European countries, it's higher because this mutation of Rh antigens probably occurred in Spain or Portugal area. So they are the origins of the blood group. Because of that, they are in their population about 15% are rhesus positive. About 1/3 of Rh negative mothers by chance will carry a Rh positive baby. The chance of antibody generation depends on several factors. See, if a single cell passes, that will probably not trigger the maternal system to generate an antibody. The immunogenicity of the antigen itself, whether the fetal cell has capital D or simple C or capital E or simple E antigen, depends. If the capital C is there or capital D is there, the chance of generating antibodies in the mother is higher with capital D containing red cells from the fetus. If the fetal cell has capital C, it is not that immunogenic, so it will not generate the immune response from the mother. So it is less potential. And on top of that, there is a protective mechanism working on top of the rhesus system, which is the ABO system, which is the dominant antigen antibody system. So if a rhesus negative mother at the same time carries a different ABO group baby, say A negative mother carry a B positive baby, so ABO system is very quick because its antibodies are already there. The antibodies against in A negative mother, she will have antibodies against B blood group, and if she is exposed to B positive blood cells, her system will slowly develop antibodies against Rh antigen as well, but that is a slow process. The anti-B antibodies are already there, so immediately at the entrance of fetal cell into the mother, those antibodies against B will go and lyse the red cell from the fetus. So there is no chance of developing antibodies against the rhesus positive cells of the fetus. So that is protective mechanism. Now because of that, if the blood groups are also complete, the ABO group are also different, they will not have much chance of generating antibodies. So the amount of blood, the immunogenicity of the type of antigen, and mother's ABO group are all are important factors in also determining the amount of or the risk of antibody generation. This table shows you the distribution of rhesus antigens in the world population. White Caucasians 15%, Asians less than 1, Africans 4, Eurasian 2 to 4, Basques, people who are living in Basque region of Iberian Peninsula, where Spain and it's actually Spain, where the Barcelona is there, a famous city. This is thought to be the area where this Rh antibody initially came out. antigen originated. So they have naturally a higher incidence. Americans, Native Americans, Red Indians have very low levels. So people who have interacted with people from Basque region like us through Portuguese or African Americans, South Americans and other Europeans, because of intermarriage and because of colonialism, they will carry increasing rates. In Sri Lanka also, in the coastal area, Puttalam to Matara area has higher incidence of Rh negatives compared to central regions of the country. So your Rh positive negativity indicates how many of your previous relatives had any contacts with in our country, Portuguese or people from West. So they have given you the Rh system. So what are the predisposing factors for this Rh isoimmunization? In a normal fetus, a negative mother carrying a positive baby, or even same blood group mothers, the fetal maternal transfusion silently occurs in about 1% of cases. In case situations where there is a possibility of bleeding in between the baby, like miscarriages, ectopic pregnancies, or when we go and put needles like amniocentesis or choriovenous sampling, or when we manipulate the fetus like external cephalic versions, or any abdominal trauma, antepartum hemorrhages, or at the time of labor and delivery of the placenta, there is a possibility of transfer of the mother cells and the baby cells. So the baby cells can cross into the mother. Initially, when there is a transfusion or fetal cells being present in the mother, it will raise a small IgE mediated response. If another repeat transfusion occurs, then it will cause IgG mediated rapid response and antibody levels will raise. They are kind of memory linked phenomena. So we know in our immune system, initial response is through IgM, it's a small one, but the memory cells mediated IgG mediated response is the longer standing and very massive response. So those IgGs are raised in very large numbers and they will cross the fetal placenta and damage the red cells and cause hemolysis. It results in fetal anemia. When you have anemic, your heart goes into a high output cardiac failure. So when the cardiac failure occurs, fluid accumulates in the baby's skin, pleura and peritoneal cavity. It causes high drops of edema and death ultimately. Even if the anemia or hemolysis doesn't move into the level of heart failure and causing fetal death in utero, the amount of hemolysis, if it is very high, until delivery, that hemolysis byproduct, so the bilirubin, will be processed by the mother. But after delivery, mother will not be processing the bilirubin from the fetus, and they will be left to be processed by the immature fetal liver. If the fetal liver cannot handle the high load of bilirubin, bilirubin will accumulate. Bilirubin is not friendly with the baby's brain. They will go and deposit in the fetal brain areas and basal ganglia and will cause a condition called kernicterus with fitting and abnormal movement behaviors. And then it can lead into complications later in life of the fetus. Some of the fetal bilirubin which are processed by the fetal liver will be excreted through fetal urine and that will stain the amniotic fluid. So, in a condition where you have a lot of hemolysis, the amniotic fluid will be yellow because of increased hemolysis coming from the fetal liver. And that bilirubin can be detected by looking at the amniotic fluid, which is obtained by amniocentesis. So, initially when we wanted to assess the amount of hemolysis, we used to take a sample from amniotic sac with the amniocentesis, so passing a needle into the amniotic cavity, took the sample, analyzed it with colorimetric methods to assess the amount of hemolysis which has gone on. So, this is a baby who is hydropic, edematous. You can see the pot belly, even the thorax is there. Skin is edematous, the baby's face, limbs are all puffy because of fluid accumulation. Not only the fetus, even the placenta is hydropic. Placental tissues are edematous, which is again a fetal tissue. This is ultrasound scan of the fetal abdomen. You can see fluid. This is the fetal liver, this is the stomach, around them fluid. So, it is called fetal ascites. This is the basal ganglia filled with bilirubin. As we know, basal ganglia is important in our movement control or coordination. If they are filled with toxic bilirubin, they are not functioning normally, and the baby will have a lot of abnormal movements and developmental disorders and learning difficulties. So, they are not healthy babies. So, this will show in a nutshell what we have been talking all along. So, rhesus negative mother does not have any rhesus antigens. Rhesus positive fetus has rhesus antigens. During a fetal-maternal transfusion, positive fetus cells will cross into the mother. It sensitizes. This first exposure is called the sensitization exposure. Now, the mother is sensitized. She is rhesus negative. Then, there is a re-exposure or second wave of fetal blood coming onto the mother. That produces rhesus anti-D antibodies, mainly of IgG class, which are capable of crossing the placenta. So, they will pass transplacentally into the fetus, causes hemolysis and results in anemia. Anemia causes heart failure, and fetal heart failure causes fetal cardiomegaly, edema, ascites, and position of the fetus adopts called inverted Buddha, because basically the edematous baby will be like somebody who is meditating. And generally we call this water-filled baby or hydrops fetalis, which has been known even to Hippocrates. That is why this name came. And polyhydramnios. Ultimately, the fetus dies. In utero, as I mentioned earlier, bilirubin produced by the fetus due to hemolysis is taken up by the placenta and the medullary liver, and not a problem. After bilirubin, liver is faced with increasing demand, cannot handle, especially if we deliver these Rh negative babies or affected sensitized babies prematurely, then we will be in more trouble. It will raise since their livers cannot handle bilirubin, it will increase their bilirubin levels, hyperbilirubin. When it is in high levels, it will cross easily to the brain deposits in the basal ganglia and cause kernicterus, and disability and death is the result. So, with regard to a rhesus negative mother and a positive baby, these are the possible scenarios. They will deliver normally, no sensitization, there is no blood, insignificant amount crossing into the mother system. There is mild activation, that means there has been some transfusion from the fetus to the mother. Mother will be producing IgM antibodies, and second exposure again triggers a second wave of IgG, but the amount of antigen antibodies produced by the mother are low, so mild activation. There will be hemolysis, but the baby can cope. Baby's hemopoietic system can cope up with the lost red cells, so it will go on till term. Those babies will be yellow most of the time. They will be needing some sort of support. Phototherapy is the treatment. Sometimes we might deliver them prematurely, and if the amount of bilirubin is high, they will need exchange transfusion. Basically, all the cells, the blood from the baby will be taken off and transfused with mother's the blood cross-match with the mother's blood. Sometimes instead of waiting till delivery to do the exchange transfusion, we can do intrauterine exchange transfusion. If we cannot do any of those, and if the activation is very high, baby can die. Sometimes after delivery, babies die. Fortunately, they are very, very rare, as our care is now fairly well streamlined and optimal. So, can we do anything to prevent it? Yes. One is to be aware about potential sensitizing episodes, which I mentioned earlier, and give the mother antibodies raised against D antigen. They are called anti-D antibodies. So, it is produced now recombinantly. Initially, it was taken from horses, but now we have recombinant anti-D antibodies, it comes as a powder. We can make it soluble and then inject to the mother as IM injection or IV injection. Both ways it is possible to give, and that anti-D will go and hunt down any D positive cell. Remember, this is against only D antigen. Since it accounts for 85% of sensitizations, it makes sense to raise anti-D against only D antigen. We don't have anti-capital C, or simple C, or capital E, though they can still cause hemolysis. And giving anti-D probably is not going to do anything. So, at the present state, we analyze only D positive mothers. There are Rh positive ladies with simple C, capital C, and we don't treat them with anti-D. So, only about 85% of possible sensitizing episodes are covered with our anti-D treatment. But we can give it immediately after any possible transfusion occurring between mother and baby. But as I mentioned earlier, about 1% of transfusion between the mother and the baby occurs silently. So, we cannot prevent all sensitization episodes. So, instead of waiting for certain sensitization episodes, some people suggested, why don't we give it routinely to every woman who is Rh negative to catch those 1%. So, they started giving routine antenatals, doing antenatal screening of mothers, identify all those who are having the antigen by screening, and then give them prophylactic antigen. That was successful. So, they started giving it at 28 weeks and 34 weeks. will that reduce the amount of sensitization. So I mentioned about the sensitization episodes, and giving anti-D is the most effective way. Even prior to 28, 32, or 34 weeks, at any sensitization episode like threatened miscarriage, repeatedly coming with bleeding, or ectopic pregnancy, we need to cover the fetal cells which are coming into the maternal system by giving anti-D. But it doesn't start until 12 weeks. Under 12 weeks, the risk of sensitization is low. Generally, the fetal cells do not show, or it does not have antigens on the cell surfaces. So until 12 weeks, if it is only one bleeding episode, we are not bothered. But if it is repeated, as red cells don't always switch on their antigens at 12 weeks, some of the red cell population may still be having antigens. So to cover that, if the repeated bleeding episodes are there, we will give half dose of anti-D. From 12 weeks to 20 weeks, you need to give, after any sensitizing episode, half a dose. That dose can be repeated if there is repeated bleeding. But if you have ectopic even at 8 weeks, the amount of fetal blood coming into the maternal system is higher. Because of that, it is treated with the same dose. About 20 weeks, we give 500 international units. After delivery, because the risk of larger level fetal-maternal transfusion, we check the baby's blood group and give anti-D within 72 hours. So generally, anti-D amount which we give is adequate to cover 4 cc of fetal cells entering the mother. But if we want to know exactly how much of fetal cells has come into the maternal system, we have a test called Cry-Howard testing, and it will exactly allow us exactly calculate the amount of fetal blood which has come into the maternal system, and we can calculate the amount of anti-D needed. So what are the indications for anti-D? We have in the first trimester any ectopic, surgical or medical termination of pregnancies, or even miscarriages with very heavy blood loss needing a surgical evacuation, or chorionucleus sampling, because this allows a sizable proportion of fetal cells coming into maternal system. Even when they are not having much antigens on their red cell surface, possibility of sensitization is high. Our aim is to reduce the amount of first sensitization. After mother is sensitized, there is no point giving any more anti-Ds, because the mother system has got the knowledge and it will keep that in memory, and it will be bracing in any subsequent sensitizations. In the second trimester, any amniocentesis, threatened miscarriages, APHs, any blunt trauma, so after even any road traffic accident, you need to consider giving anti-D. After 28 weeks or third trimester, we give routinely at the 28 and 34 weeks. But in our country, because the incidence of anti-D RH negativity is low, it is not economically viable to give this. So we have been giving it earlier. For about last 10 years, we have given it up. Now we treat only cases which have been detected by antibody screening, but we still continue to screen everybody at 28 weeks or 34 weeks for any Rh antibodies or unexpected antibodies. If they are positive, we monitor them and give. But in any mother, if you are following in the first or second trimester, if there is any sensitization episode, it is still possible to give Rh prophylaxis because of the expensiveness of anti-D and immunoglobulin. It is not possible to give to all women. That is why it is stopped. Any APH, ECVs or delivery, trauma again in third trimester warrants anti-D administration. How do these babies present? Because they are silent inside the mother's womb. Any signs and symptoms are very late, most of the time not that useful. So the classic way of assessing a baby any disease cannot be applied in fetal diseases. That is a disadvantage. So in advanced diseases, when the hemolysis has gone into very severe levels, where the baby is really anemic and having cardiac failure, the baby's movements will reduce, become feeble and may become absent. It will lie still. That is why it is called this inverted Buddha appearance, because the baby approaches the posture which is more energy conserving. And it is actually something similar to meditation posture. That may be the reason why people who are meditating adopt that posture. So it is called the inverted Buddha posture. Baby will slow its growth, lico will accumulate, polyhydramnios, fluid accumulation under the skin will be noted as fetal hydrops. So because of that, waiting for signs and symptoms or ultrasound to detect it is late. So we don't go with that. Rather, we will detect the disease by routine antenatal screening. So every Rh woman who is identified will be followed up several times. So that is why knowing the mother's blood group is important in antenatal care. So in the first series, you should check everyone's blood group. If you see documented evidence of mother's blood group, use it. If not, get the test arranged through a blood bank and get the report quickly. I have seen women coming even at 22, 24 weeks without the blood group in their record. So if you are a MOH running an antenatal clinic, it is your prime duty to get your mother's blood group as early as possible. So that will reduce unnecessarily late identification of Rh negative mothers. If we can identify Rh negative mothers, we can start screening them for sensitization. So if by 12 weeks, if we know that mother is Rh negative, we can get her antibodies for Rh detected by Rh antibody screening. And they can get antibody screening for Rh. And then maternal serum antibody level or anti-D titer is measured if it is positive. And then if it is positive, the blood bank will start managing the case. They will ask us to repeat every week or every 2 weeks or every 4 weeks. If the mother is negative for Rh antibodies, we will follow them again at 28 and 34, 35 weeks. If a mother has raised antibodies against Rh system, out of which, as we discussed earlier, anti-D is the most important, its titer is measured. Generally, this titer is expressed as a number 1 in 32, 1 in 64 like, or you can express it with international units, which is the modern way. In severe disease, it is rare at titers less than 4 international units. Moderate risk disease or the damage to the fetus is possible at 4 to 15 units per ml. More than 15, severe anemia in the fetus is in 50% of the cases, so it's quite common at higher levels. If you go with the titer expression with number, anything more than 1 in 16 needs regular follow-up, and things which are above 1 in 64 needs probably thinking of delivery. The problem with Rhesus antibodies is that the level doesn't rise linearly. So it is possible for you to have 1 in 16 or 1 in 18, 1 in 128 rise, say 1 in 16 now, and then 128 the next moment, or the next sample. So sudden rise is quite common and is very significant. So this picture shows how it is done. Everybody, all pregnant women will get their ABO status and D blood groups. If they are positive, their antibodies are also screened. If in our setup, this is not automatically done. The blood bank will initially report, and then it is up to you to send the sample back again for them to detect, because the amount of blood which we send for grouping is not adequate. They cannot do antibody screening, and it is long drawn process, so the serum is unusable. In other countries, these things don't happen that way. So they will have enough serum to do antibody screening at the same sample, and they do it quickly because these things are automated. We do it manually because of that. It's not possible to screen all negatives at the same time of diagnosis of their blood group. So it is left for us, the doctors, to detect it and send back another sample by recalling the mother and get her antibody screening at booking. If antibody is detected, they are tested monthly until we reach 1 in 16 titer. If it is more than 1 in 16, then you get for 2 weekly follow-up. So that is the normal follow-up until you see a sudden rise in antibodies. If you do have other antibodies, just routinely follow up. No antibodies, no more testing at 28 weeks, but Rh negative, but no antibodies. Recheck at 28 weeks and around 34-35 weeks in our setup. Another one. And then repeat testing. If they are detected any antibodies, you follow them regularly with 2 weekly intervals. Let's see. After delivery, get another sample from the fetal blood, cord blood, for direct and testing, or direct Coombs test, hemoglobin, serum bilirubin, and retic count if the baby has been sensitized, and to determine the baby's blood group. And if the baby is positive, we give anti-D. So this is generally the process which follows. Check the titer, check the father's blood group and genotype. In Western countries, they don't check the fathers because it is difficult. Because of their promiscuity, it is difficult to tell exactly the father is the man who is living with the mother. So because of that, they don't check, to reduce unnecessary family violence. But in our setup, probably you can. If the father is Rh positive, check the fetal blood group. We can check that by taking cord blood or amniotic cells, but now we do it non-invasively. you can detect the cell-free fetal DNA in the maternal blood sample. Accuracy is 100% in Rh genotyping. So you don't really need to take fetal blood. The fetal cells after cell-free DNA is circulating, and that will tell the maternal blood. So if the mother is negative, there is no D gene in mother. So if you see D gene, it is definitely coming from the fetus, and it will help us to identify. So if somebody is having anti-D, you check the titer regularly, and if the titer is going beyond 1 in 16, you start close monitoring. When it is more than 1 in 64, you start looking for other signs of fetal damage. So once you detect that the antibody titer is rising, the repeated measurement of antibody titer is not that useful in clinical management of the baby or the fetus. So we start following those fetuses regularly, most of the time weekly or every second week, for signs and symptoms of fetal anemia. That we do by checking the middle cerebral blood flow. So if you are anemic, your circulation system works rapidly, pumps more blood, so the blood flows are high. Since your high blood flow will have high velocities in the brain middle cerebral artery, that can be detected. It is a sign of developing anemia, and it is used for checking the evidence of fetal hydrops. And apart from that, you can check the baby's growth, monitor kick count chart to assess how well the baby is responding to anemia, developing anemia. If you really want, you can do amniocentesis or chordocentesis, take a fetal blood sample and analyze it for hemoglobin. And if the anemia is there, you can at the same time give an intrauterine transfusion. If the baby is mature enough, or you can manage the baby safely in your system, you can deliver them. That is the other treatment. So we can monitor, we can treat them in utero with external transfusion like intrauterine transfusion, and or you can deliver. This is the middle cerebral artery. This is the circle of Willis, originating from the middle cerebral artery. These are the sphenoid wings. If you can remember your anatomy, there's a bone in the base of the skull called sphenoid bone. It has wings like a bat's wing. Along that goes your middle cerebral. So we sample or take a reading of the middle cerebral artery blood flow here. And this is the pattern of the blood flow. You can see in the systole there is blood, and in diastole also there. In normal form, the middle cerebral artery blood flow is like this. There's no flow in the diastole, in the middle cerebral. But in anemic patients, the vessels in the brain are dilated, so that there will be some flow even during diastole. So that is a sign of anemia, and we use that even in monitoring of IUGR babies. As a response to developing hypoxia, the baby's middle brain blood vessels dilate to accommodate more blood. But what we are interested here is not the diastolic flow. What we are interested in is the amount of the red cell which flies very rapidly or moves very rapidly. So this peak velocity, this is the peak velocity in a non-anemic fetus may be somewhere here. Here it is high. So that value is taken. Now here the value is 64.8 centimeters per second. So red cells are flying at 64.8 centimeters per second, which is high. And we can use that value to calculate the fetal red cell velocity. and that value in centimeters per second is plotted here. So this is a normogram. For each POA, the normal values are there. So this is the median value, this is 1.5 multiples of median. So we can see that if you plot the fetal value somewhere here, it is higher. If the fetal value is somewhere there, it is still slightly okay. If it falls in there, it is a median value. So higher the deviation, higher the anemia, and that will help us to decide whether we should keep the baby or deliver the baby. Generally speaking, from around 34 weeks and onwards, we don't keep anemic babies anymore. We usually plan and deliver them. After the delivery, if you need, you can assess the fetal hemoglobin directly and or with the cord blood, and then arrange exchange transfusions. If the fetus is non-hydropic, with fetal intrauterine transfusion, if the fetus is very premature and unable to deliver, we can give transfusions in utero. The survivals are in the range of 90%, so very high rate of survival. Even with high drops, if we deliver, about 75% will survive. Except premature delivery of these fetuses, management of isoimmunization is not a long-term problem or effect. So if you are looking after a rhesus negative mother with a rhesus positive baby, if you think that the baby might need the exchange transfusion, keep blood ready for the transfusion. Inform the PBU, they will cross-match with mother's blood. After the delivery, usually we do delayed cramping. Here we do not do delayed cramping. This is one incident. HIV, hepatitis B are other conditions where we don't perform any delayed cramping. So cramp the cord immediately. Keep the cord length long for possible umbilical vein catheterization, which is necessary for exchange transfusion. So leave about 1 or 2 feet of cord if it is possible. Then it is easier for them to prune and give repeated transfusion if it is necessary. You can collect cord blood for blood grouping, bilirubin, direct antibody test or direct Coombs test, and arrange exchange transfusion in liaison with the neonatal team. We don't see severe hemolytic disease of newborn with the hydropic babies anymore. As I mentioned earlier, as we do not cover all possible fetal-maternal transfusions by giving anti-D or monitoring and giving anti-D, isoimmunization from other non-rhesus antigens are becoming common, like KEL, anti-C, simple C are common. Anti-D is the rhesus disease, but anti-simple C, anti-KEL we don't cover. They are can be a problem. And I mentioned earlier, anti-KEL antibodies go and damage the bone marrow and cause anemia. So as a doctor, you need to be aware of why it is important to group the mothers, detect their blood group early, how we follow them up if they are positive, they are carrying a negative mother carrying a positive baby, how we screen them regularly with unexpected antibody screening and booking at 28 and 34 weeks, and if they are positive for antibodies, how they are followed up regularly and detect the antibody titers. Once the antibody titer is present, we still follow them with antibody titers, but we start fetal monitoring, kick count chart plus ultrasound scanning and middle cerebral artery peak systolic velocity, and then deliver or treat in utero appropriately depending on the maturity of the fetus. So that is in a nutshell what we do for RHP. If you have any questions, you can raise them in comments and clarify the issues if you see a case in your clinical appointments. Thank you.